next up to speak about this topic is Dr. Megan Fix. As an aside, somebody texted me and said, why are all the women speakers at the end? Of course, we saved the very best for last. And partly also, people are scheduled based on their time zone so that when we get to the end, Joelle, who's in California, we didn't ask her to wake up at 4 o'clock in the morning for this. But Megan's out in Utah. She's an associate professor in the Department of Emergency Medicine at the University of Utah. She's also assistant dean for student affairs. She's vice chair for education out there. Dr. Fix has been involved in education at quite a few national and international conferences, including the Difficult Airway course, which is taught in multiple sites around the country, and also the CORD conference that just concluded, the Council of Residency Directors in Emergency Medicine Conference. She's one of the associate editors for the online textbook Corpendium. She's received multiple awards, including ACEP's National Faculty Teaching Award just a couple of years ago, and really just a wonderful, wonderful speaker. And she's going to be spending some time talking about this concept that one size doesn't fit all, some special circumstances in special populations. So Megan, thanks for joining us, and we'll hand things over to you.
Fantastic. Thank you so much, Amal. And I also want to thank all of you out there in the audience from around the world for tuning in to this amazing cardiology symposium. Again, my name is Megan Fix, and we are going to talk about special populations, namely 3. I also want to thank the other amazing speakers. These have been amazing talks, and also all the folks at University of Maryland, Amal Mattu, Mike Bond, Doreen, Lean. Everybody's been so great to work with. So let's get right into it. I do not have any disclosures, but Amal emailed us last night and said, have fun with your talks. So we're going to have some fun with this one. Like I said, we're going to talk about 3 populations, and I've chosen 3 songs to remind us of one of the most important things about cardiac arrest. So we are going to talk about these 3 special populations today: pregnancy, obesity, and hypothermia. And as Amal mentioned, there are lots of differences in the management of cardiac arrest with these populations, but there is fortunately one thing that is definitely the same around all of these populations, and we've talked about it before today, and that is high quality, amazing chest compressions and CPR. This saves lives. And you want to remember the rate of 100 to 120 beats per minute for all of these populations. Now we'll get to hypothermia and how long you're going to do CPR, but for now, I want you to remember, high quality, amazing chest compressions and CPR is a tenet of cardiac arrest for all these populations. We're also going to talk about the differences, and largely this comes down to preparation. How do you get ready for these patients coming in? How do you position them? And what are the special things that we need to talk about? For all of these circumstances, they don't happen that often, especially with pregnancy and hypothermia, and so don't be shy. Call your friends. And I highly encourage you to establish protocols in your institution. I'll give you a few examples later on. But for example, for any maternal cardiac arrest that comes into our hospital, we have something called an OB code, where it pages out everybody and everyone who might need to be involved. Similarly, for the obese patients, you need helpers to establish IV access and for airway. And then for the hypothermic cardiac arrest, you ideally need ECMO. So you want to have friends, maybe not at your hospital, maybe at a different hospital who can do that. And finally, you want to have everybody in the room that you can. And this is really important for the positioning and the help with IV access, and we will get into it. So call your extra nurses, your techs, your medical students, your visiting medical students, because they can definitely help out. So my first song in the maternal cardiac arrest to get us thinking about those amazing chest compressions is Baby Shark, do-do-do-do-do, Baby Shark, do-do-do-do-do, Baby Shark. So who knew that Baby Shark is actually a training song for cardiac arrest? You can Google this. There are lots of trainings out there that use Baby Shark, but I thought it was fitting for maternal cardiac arrest. And if you really want more songs, there is a Spotify channel for cardiac arrest songs that are at that key 100 to 120 beats per minute. So there isn't a ton of data for this population, but I really wanted to focus in this talk on the high points, the guidelines. These are the guidelines I want you to remember. The AHA put out this statement in 2015. They updated some of their statement in 2020, and I'll reference that a little bit later. And then the European Resuscitation Council, or I'm going to shorten that to ERC, they put out amazing guidelines in 2021. I highly recommend, if you're interested in these topics, to read those guidelines. They have flow sheets, a lot of different populations that we don't have time to talk about. So you got to prepare. You get a call that you have a pregnant patient coming in either peri-arrest or in arrest. Call your friends. And I want you to remember, everybody can be involved. This is the OB team, the NICU team, neonatal intensivists, anesthesia. And then positioning helpers is really going to be important for this population. And I'll show you in a moment, but this is now called left uterine displacement. So you're going to need people to do that. You also want to remember that you could be in a situation of doing something called a resuscitative hysterotomy. We'll talk about that. It used to be called perimortem C-section, but that can be a life-saving maneuver in these patients. You also want to remember to find your infant equipment. You may not have used this for many years, but see where it is, warmers, etc. And then you need somebody who's going to be your timer. And remember this, 4 minutes, okay? I want you to remember 4 minutes because that will be very important later. But we all know 4 minutes can go by very fast in a cardiac arrest situation. And as the patient's rolling in, I want you to check their fundal height, because you want to know if they are above the viability zone, which would be around 20 weeks, or the level of the umbilicus for the fundal height. And then you're going to assign roles. So for each of these populations, we're going to have a slide on what's the same in cardiac arrest with general management and what's different. And then we'll unpack each of those. So for the pregnant population, what's the same? Well, CPR, as I mentioned, one of the tenets, high quality, amazing chest compressions at 100 to 120 beats per minute. And you want to do the same depth, 5 centimeters, and the standard hand positioning. Drugs are totally the same. Whatever your ACLS protocol is, you're going to do the same drugs. It's not going to harm the fetus. And for defibrillation, you also are going to do the same thing. Same placement of the pads, same energy level. And you may think, oh, I don't know if I want to defibrillate this patient, but the alternative to not defibrillating if they're in a shockable rhythm is death. So if you defibrillate and it saves the mom, it will definitely save the fetus as well, or most likely. And so don't be afraid. If you need to shock the patient, go ahead. And then finally, the guidelines do mention that there is this thought that we should be monitoring the fetus with fetal monitors, but you do not need to do that in a cardiac arrest situation. So many other things are going on. Focus on the things that you're doing and you're doing really well. And you want to consider ECMO if it is available to you in your area. So then what's different about the pregnancy cardiac arrest? Positioning is very key here. The one thing that I want you to remember is manual left uterine displacement, and I'll show you how to do this in a moment. And previous guidelines used to say that you wanted the hands higher up on the sternum for CPR. That is no longer the case because there is not great evidence for that. IV access, the guidelines definitely recommend to put IVs above the diaphragm to avoid any obstruction by the gravid uterus. For airway, slight differences. They just mentioned to try and do a smaller ET tube if the patient is intubated because of airway edema. And patients who are pregnant are at higher risk for hypoxia. So they definitely mentioned to use 100% oxygen. And remember, 4 minutes is the timing that you want to make the decision to do a resuscitative hysterotomy. Now that comes quick. So you want to have a timer ready to tell you and your team if you need to do this maneuver. So let's unpack some of these differences and similarities. So again, standard hand position, lower portion of the sternum, 100 to 120 beats per minute for CPR. Standard pad placement, they recommend anterolateral here for pregnancy and standard defibrillation. You're not going to harm the fetus. They're actually in the guidelines recommending against using these manual compression devices. So if you have, these mechanical compression devices, if you have them, this is not the population to use in pregnancy because there's just no evidence. And so the guidelines recommend against using mechanical compression devices. Now let's talk about why positioning is important. So imagine this as a patient in a CT scan, their feet are coming towards you. You see the IVC on the right and the aorta on the left. The physiologic changes of pregnancy makes it so that the gravid uterus presses down on these great vessels, especially over 20 weeks. And so when the patient is supine, as here, you can see that those great vessels are compressed. And so that leads to decreased cardiac output and decreased venous return, both of which are very important when you're trying to resuscitate somebody in cardiac arrest or in peri-arrest situations. So you may remember, and when I was in training, we were taught to do this, left tilt. So we were taught to put the patient in left lateral tilt. And OR studies have definitely shown that if you put the patient in left lateral tilt, you will get opening up of these vessels and you can relieve hypotension. But as you know, in cardiac arrest, think about doing those amazing high quality chest compressions when the patient is in tilt. This is really difficult, and mannequin studies have shown this. So times have changed and the guidelines have changed as well. You can put the patient in tilt in the pre-arrest situation, but you definitely want to learn and practice this manual left uterine displacement because that is recommended by all the guidelines as far as when the patient is in cardiac arrest. This allows the patient to be supine so you can do those high quality chest compressions and all the other maneuvers that you're going to do. So here you see, I think the better practice is to have one person solely doing this job, and they're going to be on the patient's left, and then they're going to take both of their hands and move the gravid uterus leftward and upward. This is really important. You don't want to press down because that will then compress those great vessels even more. So you want to press leftward and upward. If you are in a situation where you have less providers to help, you can do the picture on the right, which is the one-handed technique where you actually press from the patient's right, again, leftward and upward. This is called manual left uterine displacement, and I want you all to remember this as a key point in maternal cardiac arrest. Now, the guidelines mention that in pre-arrest situations, if the patient's very hypotensive, you can do tilt or left uterine displacement, but you really want to make sure that you are doing some positioning of that gravid uterus throughout this pre-arrest arrest period. So again, during arrest, you definitely want to be doing this manual left uterine displacement. Okay, remember in the beginning, we said get a timer and check that fundus to see how far along the baby is. This is really important, and this is the reason why. So the guidelines recommend that we should do the life-saving maneuver of resuscitative hysterotomy if there is a fetus that is potentially viable. And that is around the area of 20 weeks, which is the umbilicus when you palpate on the abdomen. And so we want to be ready to do this. It's super scary, but it can save lives. So 20 weeks, level of the umbilicus, be ready at 4 minutes. Driving home those points again, this is the statement from the guidelines in the ERC. Over 20 weeks at the level of the umbilicus, if it's no ROSC within 4 minutes, be ready to do what they're calling emergency cesarean, resuscitative hysterotomy, because they say that you want the baby out within 5 minutes. So let's say that again. Make the decision at 4 minutes. You do the procedure in 1 minute to ideally get the baby out at 5 minutes. Now, there have been cases of survival much longer time without ROSC in maternal cardiac arrest, but I want you to remember this because this is a quick timeline. This is the ACLS update for 2020. Again, we'll show this bigger. Here you see, if no ROSC in 5 minutes, you really want to do what they call perimortem cesarean delivery. And again, remember continuous left uterine displacement. Okay, resuscitative hysterotomy. I'm going to talk a little bit about the terminology. We used to call this perimortem C-section. And even just saying that, perimortem C-section, it just gives me the heebie-jeebies because you're talking about basically right around death. But the whole point of doing this procedure is to save mom's resuscitative efforts and hopefully baby, either or both. So this is really a life-saving maneuver, and so we should speak to it as such. So I like to use the term, and this is the newer term in the literature as well, resuscitative hysterotomy. The procedure is the hysterotomy, and that is in order to resuscitate the mom. This is a list of equipment that you may need, and you might want to just have a kit. Actually, I recommend you have a kit ready for the rare case that you're going to need this. Because remember, 4 minutes comes fast. So if you can put this kit together, have that available so that someone can grab it while you're doing your resuscitative measures, that is what you should do. This is from the AHA guidelines, and the real only thing you need to start the procedure is a scalpel, and they recommend a number 10 blade. We don't have time to go into this, but these are the steps. You want to continue your amazing high quality CPR, get a little antiseptic on there, make a vertical skin incision, a big one, from xiphoid to pubis. Retract the bladder ideally, and then you're going to cut the uterus, the lower part of the uterus. Then you're going to cut up in the uterus to the baby, deliver the baby, again, within 5 minutes, and then clamp, cut the cord, hand baby off to the NICU. Now you're sitting there with an open abdomen and an open uterus. And ideally, with your code, you will have OB or even general surgery available to help you with this. If not, you can actually sew up the uterus with absorbable running suture that are locked sutures. Oh boy, this is a very scary thing, and I hope you never have to do it. But remember, you really can do this, and this is in order to save baby and mom. And I want you to remember 4 minutes, have a person ready to time this so that you can do this if needed. So summary for pregnancy, I want you to remember positioning. Manual left uterine displacement is in. You can still do tilt, but not during CPR. You want to do leftward, upward movement of the gravid uterus. For standard ACLS, it's same in pregnancy. Standard rate, standard depth, standard hand positioning. Don't use mechanical compression devices. And again, 4 minutes comes quickly. Be ready for that resuscitative hysterotomy. Let's move on to our next population, obesity. And the song I picked is... Did you think I could lay down and die? Oh, no, not all. I will survive. Oh, as long as I know how to love, I know I'll be alive. Gotta love Gloria. So again, amazing high quality chest compressions are the key similarity with this population. There's not a lot of recent data, but there's some great review articles that I've put here for you. The ERC guidelines are, again, really excellent for this population. The AHA hasn't really updated this population since 2010, so I didn't include those guidelines, but these are really good resources and what's referenced throughout the talk. So again, in the obese cardiac arrest, preparation is key. Call your friends, and especially here, you are going to need friends for airway, respiratory therapy, bagging. This is a real big thing that's different in the obese population. You're also going to need friends to help with access. Access has been shown to be difficult in the obese population, so get out that ultrasound that Haney loves and do some ultrasound guided lines and consider an A-line during the arrest. You also are going to want to call your medical students and everybody else to do compressions. And in the guidelines, they specifically mention that you want to have compression turnover more frequently because these compressions are harder to do. And if you have an amazing pharmacist, like I do at my institution, call in your pharmacist because drugs can be different in this population as far as the dosing. So what is the same? CPR, again, same high quality, amazing chest compressions. Previous guidelines said to move the patient to the floor. You do not want to do this. And then some of the drugs are the same, namely epi. I talked a lot about epi today. Thank you, Corey and Tarlin. But epi for the obese population is still the same as far as dosing and recommended administration. Defibrillation is the same in terms of the placement of the pads. They do recommend maximal energy, which I'll show you here. So what is different about the obese population? You want to have your hands actually higher on the sternum. Now, as opposed to pregnancy, there is actually literature to help us with this. So guidelines recommend in the obese patient, you don't want to be at the lower end of the sternum, probably more mid. You want to change your compressors frequently because harder to do. And you want to do deeper compressions. As opposed to 5 centimeters, try to go 6 centimeters. Access can be difficult. So again, consider an ultrasound IV and A-lines. And then airway. Now, this could be peri-arrest or in arrest, but you do want to consider ramped positioning if peri-arrest and when you're doing pre-oxygenation, because that will help relieve some of the weight from the abdominal girth. And then bagging is really difficult in these patients sometimes. And so you want to ideally minimize bagging if you don't have to, but if you're going to have to bag, use 2 people with really excellent technique. And I'll show you how to do this. That really helps overcome the airway resistance in the obese population. And then for defibrillation, same positioning, but they say to go big. in the guidelines start with the max energy at 200 joules. So let's unpack a few of these. Again, for CPR, you want to have higher, so a little bit higher on the sternum, because in obesity, the abdominal girth pushes up the diaphragm. And so ideally, you want to have really high quality chest compressions. Now, this vary in exact science. They say higher. If, as Haney mentioned earlier, you have access to a TEE, that can help you realize if you're doing high quality compressions. But suffice to say, for now, the guidelines do recommend a little bit higher hand placement, deeper compressions, remember 6 centimeters, and more frequent compressors. This is the study that the guidelines reference as far as why we put the hands higher. It's some CT imaging and fancy math, and essentially shows in the obese population, the OP, or the optimal point for chest compressions, is more cranial. Now, remember again, these are harder to do compressions, so you want to have deep compressions, 6 centimeters, and that allows for full recoil. And there are actually bariatric CPR mannequins that you can practice on if you want to practice this with your folks. So mechanical chest compression devices, as opposed to pregnancy, they are recommended. The problem is that depending on how big your patient is, they may not actually fit. So as the patient's coming in, I highly recommend, if you have one of these, to have somebody actually measure before you try to put it on the patient, because there are limitations in the size. Now, again, defibrillation, the guidelines say to just go for the gold and go for max shocks in terms of the joules. Now, the drugs. I do not have time to get into the nuances of this. Some drugs are total body weight, some are ideal body weight, some are lipophilic, some are hydrophilic. This is where it is ideal to offload your brain and have your pharmacist help you. If you don't have a pharmacist, just do the standard. That's what we all do. But if you do have a pharmacist, some of these drugs should have a little bit of change in dosing. This is from one of those review articles, and I just want to highlight again, these are the critical changes in obesity and cardiac arrest. These are the drugs that they mention over here. Now, again, adrenaline or epinephrine is going to be the same at 1 milligram. Feel free to peruse this, but if you do have a pharmacist, help them help you offload your brain. Now, for peri-arrest, if you're doing airway and you're doing pre-oxygenation, these papers really recommend to try and get the patient in either a ramped or a semi-recumbent. So one of these two positions, because that again offloads some of that weight that's lying on the chest wall. But the bagging is super important in peri-arrest or in arrest situations. We've learned both of these techniques, but ideally you want to have the best bagging you've ever done with 2 people. One person holding the mask on the patient with this VE or thenar grip. And that allows for more of your fingers to be able to pull up into the mask, not push down, smushing the face, but pull up into the mask, and then have a separate person squeezing the bag. You definitely want to do this in the obese patients, and this is recommended in the guidelines. So the summary for cardiac arrest in the obese patients, we're going to prepare. You're going to have awesome IV access. Ideally, you might need to use ultrasound, and call your pharmacist. You're going to position the patient ramped for airway, and remember, amazing high quality 2-person bagging will help you relieve some of that airway pressure. And then for special, higher hand placement is recommended, deeper compressions at 6 centimeters, and higher energy, just go for maximum. So our final population is the hypothermic population, and this song is an old favorite. I let that one go a little longer. And the reason I picked Staying Alive is not only because it's the most probably famous CPR song, but also the biggest difference in this population is that you need to resuscitate these folks in cardiac arrest for a long, long time. So you're going to be singing Staying Alive a long time in your head. And the patients we're talking about here is accidental hypothermia, not targeted temperature management like Tarlin mentioned, but the person who was out hiking in the wilderness and got cold first and then died. That is key. It's not the patient who fell off the cliff and had a spinal injury and died and then got cold. It is the patient who was out in the elements all night long, got cold first, and then died. This is the patients that we can really save for doing amazing cardiac arrest management for many hours. So think in your head how many hours you think is the longest patient to survive, because we'll show you that in a moment. So your patient, for the guidelines here, there's actually 2 guidelines that can support you. This is the AHA update in 2020. They did kind of a mini review of the guidelines for accidental hypothermia. The full review was from 2010, but this is a good reference to have. And then the European guidelines have an amazing flow sheet. So I highly recommend you read this. They did a really good deep dive into this population. So what's the same in these accidental hypothermic patients? Well, again, high quality, amazing CPR comes back at 100 to 120 beats per minute, 5 centimeters of depth, lower half of sternum, same positioning. Drugs, same drugs. There is some nuance here, and the guidelines actually differ. And I'll show you why, but you can use epinephrine at standard doses, but the timing comes up into question. Defibrillation, you can do the same thing you always do, same position, same energy. The timing comes into question, which we'll talk about. But again, many minutes of CPR. The guidelines do recommend to use mechanical compression devices if you have access to these, because this will save your compressors over many hours. So what's different? Well, a lot is actually different in this population. Transport. So with your EMS agencies, if you see patients with this circumstance, ideally you want to get them to an ECMO center. And ECMO is preferred over cardiac bypass, and I'll show you more about that. Vitals are vital here. You want to monitor the core temperature all the time if you can, and they recommend an esophageal monitor, and I'll show you a picture of that. And then drugs. So here's the rub. One guideline says that you should hold epi until the patient is greater than 30 degrees Celsius, because the myocardium is really irritated when it is super cold. And so number one, theoretically, it may not work at these really, really low temperatures. And number two, if you keep giving epi at your standard intervals, the theory is that the epi will add up and add up and add up. And then once they're warmed, all that epi will be suddenly streaming through the body and it will make them explode. Not really, but there is theoretical reasons to support that practice. Similarly with defibrillation, one of the guidelines says to hold any defibrillation until, to start with 3 shocks, and then to hold any further defibrillation until the patient again is over 30 degrees. Myocardium is really irritable. It's very, very cold, so it may not work. But I'll show you that the guidelines differ. And the bottom line here is that you can do whatever you want, and you will have a guideline to support you. And then the final difference that I want to bring up is have hope. Have hope that these people will have ROSC once they get warm, but also remember hope. Remember that there is a prognosticating score called the HOPE score. I'll show you this in a moment. This has been validated and it's on online. You can go to this and you can plug in these characteristics of the patient once they get to you in the hospital and see what their chance of survival is. You can use potassium as well. They still recommend to get potassium, but it's less reliable than this HOPE score. So unpacking these a little bit, esophageal temperature monitoring, you want to be in the lower half of the esophagus. You can see why. It's right by the heart. The whole thing with epi is that the European guidelines, again, say to withhold it if you're below 30 degrees, and then give it actually at longer intervals, 6 to 10 minutes, even when you're above 30 degrees. This for me is hard just because it's a lot of thinking and changing your standard protocols, but this is what the European guidelines recommend. European guidelines also recommend after 3 shocks to avoid any other shocks until you're warmed above 30. But wait, there's more. The 2020 update to the AHA guidelines basically said that these are all theoretical recommendations. You can shock as per usual, you can give meds as per usual, because there's no evidence to support this practice of withholding or having longer intervals. So do what you want and know that the guidelines are there to back you up. Now, remember the tenet in hypothermic arrest, patients are not dead until they're warm and dead, and this still is true. But how warm is warm and dead? I always wondered this. Neither of the guidelines actually tell you what the temperature is, but certain literature says it's around 32 to 34 degrees Celsius. That's about the temperature that's warmed. And remember, CPR can go on for a long time in this population. So how long is the longest time? It's about 9 hours. So imagine you resuscitating someone for 9 hours. Now, granted, in this case, this person got lost in the Pyrenees, in Italy, and not all of this was standard CPR. About a little over half of it was ECMO, ECLS. So remember this long time, and if you have access to a mechanical CPR device, use it. And then remember transport. If you can get the patient to an ECMO center, that is recommended much more heavily over our old standard techniques of warming, which included thoracic and bladder lavage. So remember HOPE. These are those prognosticating scores based on elements. We used to say it's bad if your potassium was greater than 12. It's still bad, but the HOPE score is more reliable and validated. These are the elements of the HOPE score. You can see them there. And this is our protocol that we made at the University of Utah. I am so happy to share this with you, any of you, if you want to make a protocol at your institution. So the summary for cardiac arrest and hypothermic patients is prepare. Remember to have your core temperature with your esophageal probe, ideally. Transfer them to an ECMO center. You're going to be doing staying alive for a long time. So if you have a mechanical compression device, please use it. You can do whatever you want with epi and defibrillation, and remember to have HOPE. Use the HOPE score and get a potassium. Remember cardiac arrest in pregnancy, positioning, manual left uterine displacement, standard ACLS, and 4 minutes to resuscitative hysterotomy. And in the obese patients, prepare with great IV access, have your pharmacist, if you can, position them ramped, 2-person bagging, and higher, deeper, and higher energy for your CPR. Thank you so much for your attention. It was really an honor to be here with you. And that is my email.
All right, Dr. Fix, thank you so much for another outstanding presentation.